Evet, obsessive compulsive spectrum.
Obsessive compulsive spectrum disorders and the role of anorexia nervosa. OCSD has been a concept that has been on our agenda for the last 2 decades, and I'm sure you're all familiar with the concept of OCSD. It was proposed by Hollander, and you have obsessive compulsive disorder is characterized by obsession and compulsion, but there are other disorders that encompass these features, and we can categorize these disorders based on the characteristics of symptoms. Body dysmorphic disorder, hypochondriasis, eating disorders, and impulse control disorders are the main categories. But there are many disorders that have similar symptoms. Studies have created rich theoretical discussions on obsessive-compulsive spectrum, and the discussions have focused on etiology and treatment. And from a spectrum point of view, the disorders can be categorized into 3. Disorders regarding body image, impulse control, and recurrent behaviors. Bodily preoccupation, impulse control, neurological disorders, and eating disorders are included in the bodily preoccupation group. And it's quite a wide spectrum. And the OCSD, in the body section, you have anorexia, and I'm sure you have all seen this. This is quite famous, and it's quite popular as well. In this spectrum, this is the compulsive end, and this is the impulsive end. And compulsions, and based on the severity of the compulsions, you get this classification. Over-exaggerated harm or underestimated harm are the 2 opposites of this line, and all the disorders are classified here: BDD, AN, DEP, HYP, TS, TTM, and so on. So, this has been in use for a while. This is the classification of OCSDs, and it has proved quite popular. But in psychiatry, we are also familiar with this concept of spectrums. We have many spectrums in our profession. Now, this also shows the weakness of psychiatry in terms of classification. That is to say, our minds work on analogies, and there are similar symptoms, and that's why we wanted to perhaps create this spectrum. We had the affected spectrums. On the one hand, there was bipolar, on the other schizophrenia, and schizoaffective in the middle. So we tend to like these things. In psychiatry, spectrums, we have many spectrums. If we can't find spectrums, we put things in sets and subsets, and within the affective spectrum, we did this as well. Obsessive compulsive disorders, by the same token, the eating disorders are also treated the same. Characteristic syndrome, or whether it's a part of addiction, whether it's a part of OCD, these have been debated for so long. And in this scheme you have addiction, affective disorders. In the middle you have obsessive compulsive disorders. So you have sets, subsets, and a whole spectrum as well, and it looks good, and we think we understand it all by using this. So OCSD was coded as an anxiety disorder by DSM-4, and not everyone agreed with this. Many people raised their concerns regarding this, and the mystery of OCD is still underway, and this is a problem that needs to be solved by psychiatrists. As psychiatrists, we need to resolve this problem of OCD. But we have also created a problem en route, which is OCSD, whether it is an anxiety disorder or whether it's an affective disorder, whether it's a behavioral disorder characterized by obsessions. These are all different topics for debate. And there are also 4 points, 4 questions that we need to answer. We need more clarity. First of all, we need to separate OCD from anxiety disorder, and OCSD needs to be accepted, and OCD has a heterogeneous structure. We need to understand it better, and anorexia nervosa relation with OCD and OCSD needs to be better understood, and now I would like to present you with certain proposals regarding these points. There are so many, there was a lot of contention, but the rationale was this: OCD starts at childhood, anxiety disorder starts at a later age. OCD has a simple gender parity, whereas in anxiety disorder you have more women. In OCD there's less substance use. In OCD families there are more OCSDs and not anxiety disorders. So these people do not have anxiety disorders, and these were demonstrated by many studies. And in the clinical experience, OCD and OCD spectrum diseases were deemed heterogeneous. OCD was taken out of the anxiety disorders chapter, and this was supported. And from a neurobiological point of view, we see that there are different neuron networks: stress, fear cycle, PTCP, phobias. You have pathologic amygdala hyperactivation. In OCB, however, in OCB fear response cyclus, amygdala is hypoactive, and this is based on biology. In neuro screening studies, these were once again demonstrated in imaging studies. Should OCD be classified as an anxiety disorder in DSM-5? When we look at cognitive functions, you have working memory, attention bias, PTSD, simple phobia. In the cognitive functions, there is a different profile, and this is the reason why the separation was supported. Again, the parity of male and female patients, neuroimaging, and so on and so forth. This table summarizes them all. And also, afterwards, in many countries, almost in a homogeneous manner, many specialists participated in this study. 108 psychiatrists, 69 psychologists, and these were all OCD specialists, and 60% said OCD should not be deemed an anxiety disorder anymore. 75% of the psychiatrists said yes, it should be taken out of the anxiety disorder classification. And their reason was obsession and compulsion is the main characteristic of the disease, not anxiety. Those who said it should stay said that you use the same medication for the two conditions. And as you know, this issue is going to be resolved in DSM-5. There is going to be a separation. So now that OCD is separate, well, when it's going away, it wants to take many disorders with it, which are deemed OCSD, obsessive compulsive spectrum disorders. And why this category was created? Well, here there will be obsessions on compulsions, and in the comorbidity, family history, and frontostriatal brain circuitry, there will be, and in the treatment response, there needs to be similarities in order for inclusion. The same spectrum is here with us once again. This is how it was created: impulsive and compulsive, and over-exaggerated harm, underestimated harm, and again, these are the disorders and the spectrum. So, behavior, well, recurrent behaviors is the basis of this theory. It includes obsession, it is said, but obsession is not really emphasized. In OCSD, what are the criticisms for OCSD? The lines are vague. When you put like and like together, you get a spectrum, and this can create a diagnostic group for you, but it doesn't tell you anything more than that. And in psychiatry, we have so many spectrums: addiction spectrum, anxiety spectrum, impulsive spectrum, addiction spectrum, psychotic spectrum. There are so many disorders included in OCSD. They need to be narrowed down, and the Professor Hug talked about this. Within OCSDs, well, in every theory you have hypertrophic, and in OCD as well, there are so many disorders, and the suggestion is, even if this is accepted, it needs to be narrowed down. And there are so many people who advocate for the narrowing down of this classification. We need to be diligent in terms of selecting which ones should stay and which ones should go. And this criticism was dealt by our group about 2 years ago. Atila Erol and his team, they have done a lot of research and studies on OCD, and OCSD does not include obsession, they said. And until I read that article, I was looking at the relationship of anorexia and OCD, and his article was an eye-opener for me. It was quite inspiring for me. And then I didn't focus on OCD only, but I looked at the other disorders included in the OCSD category. And you see the same bit of criticism here. It doesn't have a cognitive theory. I mean, OCSDs do not have this theory. You have a different pattern for OCSD. You don't have this cognitive theory, and people just ignore this. That's why it was born without cognition, as the professor said. And those who say it needs to be narrowed down, these are the criteria that are put forth, and I mean, these have a high likelihood of being included. These are low, lacking evidence. For eating disorders, you have a somewhat high or moderate interpretations. Let me continue. OCSDs are heterogeneous in nature. We have all these problems, all these concerns, and also OCD itself is heterogeneous too. There are 4 dimensions: control, symmetry, cleanliness, hoarding, and these dimensions in the factor analysis studies and in set analyses, these have been demonstrated. Hoarding, symmetry, forbidden thoughts, Yale Brown also has shown this. So these 4 dimensions have been demonstrated by clinical studies. OCD is heterogeneous, and in the treatment as well there's heterogeneity. So this has been clearly demonstrated. So let me skip this. As for neurobiological infrastructure, what is known is this orbitofrontal cortex comes to the foreground, but there are other structures, these 2, especially parietal cortex. That is to say, for OCD, we can't say that there is only one network of nerves that is responsible. There are other structures that come into the play, and we see that in many studies, units whose association with OCD has been demonstrated is anterior cingulate cortex striatum and orbitofrontal cortex. So the biological structures also vary, and there is a serious extent of heterogeneity here. Subtypes, again, there is debate here. Certain subtypes especially have to do with the control mechanism, whereas some have to do with the malfunction of the reward system, and also dopaminergic involvement might be in question. And OCD subtypes, we don't know whether there's a direct correlation with OCSD dimension. This is very important. OCD subtypes relationship with OCSD dimension has not been clearly shown. We lack evidence on this, and there is vagueness about this point. OCD itself is a spectrum. It's not a monolithic structure. There are so many different dimensions and convergences, and there's heterogeneity as well, and also there's a high prevalence of comorbidities: depression 66%, simple phobia 22%, eating disorders, alcohol dependence, substance abuse. These are the comorbidities, and many studies have demonstrated this. These are the rates that are quite high, and in comorbidity, just like the spectrum, it is another problem of psychiatry. So this was OCD. Now I would like to talk about the relationship between AN and OCD. AN has been seen as an obsessive-compulsive type since the 1930s and associated with OCD because in the cognitive structure and behaviorally as well, it is recurrent. There are so many motives that are recurrent. In AN, the most common comorbid symptom is obsession. AN and OCD is seen in females and starts at adolescence. There are so many symptoms: rituals of feeding, obsessive interest in diet programs, obsessions about body weight, compulsive exercising, restlessness, and perfectionism. In eating disorders, the rate of comorbidities is 41%, and this is quite high. And OCD is heterogeneous in itself, and symmetry obsessions are seen by 68 to 72%. So also orderliness obsession is also seen. neurobiologic structure is the parietal cortex. We have some data about this, and in anorexia, anorectic patients' obsession scores are on a par with OCD patients, even if you exclude food-related obsessions. So these patients' obsession scores are on a par with OCD patient scores, and OCD symptoms are sometimes observed before the onset of the disease and even after recovery, but with malnutrition these are sort of exacerbated, and many of these patients display perfectionism at childhood, even before the onset of eating disorders. There are other OCD like features like symptomic structure, and also there are comorbidities in AN and BN, and also in OCD patients you have a high range of eating disorders. In the eating disorder patients, in their next of kin, you see a lot of OCD. Prevalence of lifelong OCD, the most inclusive study is this. The prevalence is 41%, which is quite high. Types of obsessions, symmetry, and in another study, this is 72%, and orderliness obsessions are also found. OCD prevalence in AN is about 41%. Compared to OCD, AN eating disorders start at a limited range at adolescence, but as you know, OCD is bimodal, and it can start early and it can have an adulthood onset, and OCD male-female parity is equal, whereas in anorexia you get significantly more females. There is denial in anorexia, lack of insight, resistance towards treatment, and as for medication treatment, there are dissimilarities. We see that anorexia profile is significantly different compared to OCD. So, in our studies as well, I looked at anorexia, and in eating disorders I looked at predictors, self-esteem, family, and functionality. We looked at these components because these are quite popular. Then we wanted to increase the scope, and we looked at OCD symptoms, and we realized that one of the most important predictors is OCD. And when we looked into the reasons why this is the case, here also use obsessive compulsive disorder. In other studies as well, family functionality, I mean, they weren't even correlated. The strongest correlator was always OCD. And that's how we established the link between AN and OCD. And in cognitive disorders as well, anorexia is not resistant. When there's ideation of feeding, there is no resistance and there's no suppression. And this study focuses on OCD patients. The OCD patients suppress the thoughts, but anorexic patients did not suppress the thoughts, and this is what we demonstrated. It is going to be published shortly. So, finally, conclusions. Anorexia is not a part of the obsessive compulsive disorders anymore. OCD has been separated from anxiety disorders. This is also a welcome move. OCD is, well, this is the final situation of DSM-5. Obsessive compulsive disorders, related disorders, OCD, body dysmorphic disorder, hoarding disorder, trichotillomania, excoriation, skin picking, the others are OCD, organic and social. So it has been narrowed down. OCD spectrum disorders have been narrowed down, and eating disorders were not included in there. And just like Professor Oak said, there's a different chapter entitled Feeding and Eating Disorders. Thank you.